Recording has started.
All right. So I prepared up to maybe halfway through the eye if that's something you guys want to review, but anything before that, I'm fully comfortable in going over with you guys. Aaron and Tanya aren't here with us today because they have lab at school. So they gotta have fun at school. I have to teach you guys, but um, I guess we'll start off. You guys have any questions? I mean, it's been a while since I've seen you guys, so just any questions going forward.
I don't have any specific questions.
I have two questions.
All right.
Can you hear me?
Yeah, a little bit. You might need to speak up maybe a little bit.
What about now? Is it better now?
Yeah, that's better.
Okay, so my two things are I just want to have a better clarity on the rectus muscles of the eye, the directions and so forth, as
Uh-huh.
well as the tear production with the parasympathetic and the sympathetic with the pterygopalatine preganglionic process there. I'm a little confused and I just want to kind of get a clarified process through that.
Okay. I wasn't able to hit the lacrimal glands yet, so I wouldn't be able to
Okay.
go over that with you, but I can definitely do the eye muscles. Um, Let me just share my screen here. Do you guys know the different innervations of the extrinsic eye muscles? Like you guys know the whole like LR6, SO4, I say EE3, but everything else is gonna be 3.
Yeah, lip part made
No,
it really easy to remember that.
What's your
no, I don't know
Kadeem? Is
that.
that how you say it?
Yeah, that's how you say it.
Yeah,
Yeah.
cause
I can go over that with you, or let me just share my screen.
yeah, 'cause you
Please,
guys
thank
aren't
you.
taking neuro right now. I don't think the PA students are taking neuro. It helps us.
You guys see that okay? Yes. So
Yes,
for the
yes.
innervation of these, um, we use this little like chemistry equation almost, LR6, SO4, and then there's a 3 at the end. I say LR6, SO4, EE3. So LR6, the lateral rectus, is going to be innervated by the cranial nerve 6, which is your abducens nerve. And then SO4, your superior oblique, is going to be innervated by your trochlear nerve, cranial nerve 4. And then that 3 at the end, or what I say EE3, everything else, all the other extrinsic eye muscles are going to be innervated by cranial nerve 3, which is your oculomotor, which makes sense because oculo meaning eye, motor meaning movement. So uh, I'll repeat myself. EE3, everything else is 3. That's your oculomotor nerve. LR6, lateral rectus, is your abducens nerve, cranial nerve 6. And then your superior oblique is going to be cranial nerve 4, your trochlear nerve. So if we go through each one, your superior oblique is located on your medial side here. And we know this is medial because your medial rectus is right here. So your superior oblique wraps around on the top of your medial side here. And that's going to do a down and out motion of your eye. Okay? Your inferior oblique is a little weird. It runs down this way. It is the only muscle not attached to the annular ring at its origin. All these other muscles are attached at the annular ring, and that's just the little like meeting point at the edge of the eyeball where all the muscles originate from. But that, like I said, that inferior oblique does not go with the annular ring. Um, so the inferior oblique will go do the up and out motions. Okay. And if we move to superior rectus, these rectus muscles are a lot easier because they're located exactly where they say. So for superior rectus up here, it's going to move your up. So superior rectus is located superior and moves your eye up. Inferior rectus down here, right underneath your inferior oblique, moves your eye down. Your lateral rectus, which is innervated by that cranial nerve 6, moves your eye out laterally because it's lateral. And then so the medial rectus moves your eye in because it's medial. Okay. And then, yeah, I mean, so the important, obviously all these eye movement parts are important, but you're definitely going to get a question on differential innervations. Just make sure you know them. This is a really easy way to memorize them. You'll probably continue to carry this outside of anatomy. You've probably already done it in neuro a little bit for your PT guys. But yeah, I would say that's probably the big part of the eye muscle, especially as PTs, like the muscles are really our kind of specialty. So this is extremely important. Yeah.
Thank you.
Yep. I mean, as far as the lacrimal glands, I'm sorry I wasn't able to review them yet, but I'll definitely try to get to them. But is there any other questions about anything else?
What about like the nerves? I know today he went over like the supercilii or whatever, and then like the trochlear a lot. Do you have anything on that that kind of like helps you remember where they are and stuff?
I do have one that shows the kind of the openings of the orbit here and like the certain nerves and veins that goes through them. I think this might help. There's some stuff in the superior orbital fissure that helped me memorize them. Let me show you this picture. All right, can you guys see that okay?
Yeah, we can see it.
Yeah, let me just there. Okay. So I would say these are your three main openings. We do have some smaller openings as well. But so through this optic canal, this little small one right here next to the big one, that's going to have your optic nerve and your ophthalmic artery. And that ophthalmic artery's location is important because it runs right alongside that optic nerve. And I've said this a lot of times that if like he could ask a question like if your ophthalm or your optic nerve is severed, what blood supply could also be damaged, right? And that would be the your ophthalmic artery right there. So they run together in that optic canal. And then so here's your superior orbital fissure, which is that big one. And then here you're gonna have your branches off of your V1 cranial nerve, and you memorize that by the what is this called? Mnemonic or acronym NFL, National Football League. That will be your nasal ciliary nerve, your frontal nerve, and your lacrimal nerve. So your NFL nerves are from your branches of your V1, which is your ophthalmic nerve. And then you'll also find here your extrinsic muscle innervations. So you'll have your ocular motor nerve, your trochlear nerve, and your abducens nerve right inside the superior orbital fissure as well. And then veins here would be your superior ophthalmic vein and your inferior ophthalmic vein. So as you see, this whole big hole right here holds all this stuff as well. So Just kind of remember, okay, that's your intrinsic muscles of your eye. Those lie here. Your NFL muscles lie here, and then those two ophthalmic veins also lie in here. I would say the nerve is probably more important than the veins location, but I would still know that these are here located in the superior orbital fissure. So now we have this inferior orbital fissure, which is down here, obviously inferior to everything else. You're going to get your infraorbital nerve, which is off of your CNV2, and you also get your infraorbital vessels as well, artery and vein. You also get your zygomatic nerve off cranial nerve V2, and then a branch of the inferior ophthalmic vein is also located there. Let you guys look at that real quick. Let me know when you guys are ready to go to the smaller holes, I should say. Good? All right. Now we go to these smaller holes. They don't have as much in them, like I said. But if we start here with the supraorbital foramen or notch, this is that tiny little hole, supraorbital above the orbit. So this little hole above the orbit. So you're going to get your supraorbital nerve and vessels and your supratrochlear nerves and vessels. That's not too bad, I don't think, to memorize. But if we move on down to the infraorbital groove canal and foramen, infraorbital under the orbit, right here on the 5, you're going to get your infraorbital nerve and your vessels. And if we move to 6, your zygomatic foramen located on your zygomatic. So this is something I should have mentioned before, but you have your 3 bone connections here. You have your zygomatic bone here, your maxillary bone here, and then your frontal bone up here. So those are the borders of your orbit. So if we move on to this 6 located on the lateral side here, that's going to be your zygomatic foramen located on your zygomatic bone. Okay, and that's where your zygomatic nerve is going to come from. And then we get to 7, located more toward your nasal side right here is your nasal lacrimal canal, which will hold your nasal lacrimal ducts. And I don't know if you guys have gotten into the nose at all. Have you? Okay. Do you guys know where the drainage of the nasal lacrimal duct goes into? Anyone?
Does it start with a P?
No.
He definitely went over that. I remember seeing it in the it's like a green thing that like it's like down here. I don't remember the name of it though.
So the drainage of your nasal lacrimal duct is going to end up in your inferior meatus. Do you guys know your superior, middle, and inferior meatuses? Okay.
Oh yeah, and the little folds in the nose.
Yeah, the concha or concha.
Yeah.
So you have your superior, middle, and inferior concha, and then in between those is going to be your superior, middle, and inferior meatuses, which are the spaces. And so this nasal lacrimal duct, the drainage from there is going to end up in your inferior meatus. However, most of the sinus drainage will end up in your middle meatus. But specifically for that nasal lacrimal duct, it's going to be your inferior meatus. Okay. So if we move on to 8, anterior ethmoid foramen is located at the ethmoid right here. You'll get your anterior ethmoidal nerve and vessels. And posterior ethmoidal foramen right posterior to that anterior one, you're going to get your posterior ethmoidal nerve and vessels. Right? Any questions on that? Nope. Leave this up for 1 second. I'm gonna take it down real quick. All right, do we have any other questions?
Do you have any other way? Because I know with cranial nerve 5, the trigeminal, thank you. The
Mm-hmm.
trigeminal, do you have any more like what are they called? Like things to help you remember the branches of like V1, V2, and V3?
So I just kind of like think of it as in like I'm looking at a head, right? Like if I separate my head into three parts, right? I'm gonna get my ophthalmic up here with my eyes, my maxillary right here where my maxilla area is, and then my mandibular down here where my mandible is. That's how I've always memorized it, just to separate into parts like that. Um, you guys are good on cranial nerves in general. I mean, I'm pretty sure Dr. Liphart has gone through them pretty extensively with you guys.
Mm-hmm.
Mhm. Right. I mean, any other questions?
My questions were sorry
You're
were
good.
the parasympathetic and sympathetic, but you said you haven't gone over that, right?
Of
Of
the
the
lacrimal gland or just general of the eye?
Sorry, I couldn't hear you. My
Did you mean just about the eye or like the lacrimal gland in specific
like
or?
the how do you say it? The pterygopalatine and all and the otic and all those. I don't know how
The
to say
ganglion.
the ganglions.
Oh, the ganglions? No, yeah, no, I haven't been able to go there yet.
Okay.
But your otic ganglion is important for your parotid gland. Let's see if I can find that. Yes, your otic ganglion is going to be your parasympathetic to your parotid gland. Um, Obviously, your parotid gland produces saliva. Um,
I have
yeah.
a question.
Any other questions
Yeah, what about the branches of the maxilla? Just a way to remember them, I guess.
of the maxillary vein or nerve you're talking
Yes.
about?
Yes,
Okay.
sorry.
Um, I don't have a picture, but the important branches are going to be your infraorbital, your zygomatical facial, and your zygomatical temporal. Those are going to be your three important ones off your maxillary. I believe there's probably more like smaller branches, but I would say those are your three important ones. Um, yeah. Um, I mean, while we're here, I can go over. Sorry if you can hear my dog barking. He's distracting me. But anyway, I can go over the other branches of V1 and V3 as well. I mean, for ophthalmic, the important branches are going to be your supraorbital nerve, your supratrochlear nerve, your lacrimal nerve, and your infratrochlear nerve. Then off your mandibular, it's just going to be your mental nerve. And like I said, there's a bunch of smaller ones that are also branches, but I would say those are the big ones. Um, so I have a question for you guys. So for facial muscles, what is the main innervation for the muscles of mastication?
V3? Is that what you mean? Or like,
Yeah,
okay.
you could have just said trigeminal. That was fine too. But yeah, V3 in particular is going to do most of your mastication. Does anyone know the four muscles?
Like mediolateral pterygoid, temporalis or
Uh-huh.
and then masseter, right?
Yeah.
And so he like really harped on what was it, the lateral that doesn't doesn't it open the mouth and doesn't close it? Or he said one of them is the only one that doesn't do something.
Let me double check that for you.
No, the lateral doesn't do something that everyone else does.
Yes.
I'm pretty sure it's the only one that depresses.
Okay.
Let's see. I had it here. Yeah, so your lateral pterygoid is going to be your only one that's going to depress. And this stuff's going to be important to UPTs later, because when you check for the TMJ joints and you check the muscles around there, you're going to end up sticking your finger in a bunch of people's mouths to really palpate a lot of those. We haven't got there yet, but I had some, I guess they're third years to you guys now. They've done it to me. It's not the funnest thing in the world to have a bunch of people's fingers in your mouth trying to palpate these muscles, but yeah, it's not a fun thing.
Yeah, at my clinic, we had a TMJ, and he's like, I haven't done this since school. He's like, this is gonna be tough.
Yeah, I wouldn't. That's not something I'm interested in doing, but you know, I just found it very interesting that that's something we would have to palpate in there. But if I just go over the functions really quick of each one, since I just have them listed out, we're going to talk about, so lateral excursion. If we're doing ipsilateral, lateral excursion, it's going to be your masseter and your temporalis. So ipsilateral is your same side. I'm not very good at lateral excursion, so I can't really show you, but that's if I move my jaw this side. So the muscles on this side working will be my masseter and temporalis. And then on this side, if I move my jaw to that side, it would be my medial pterygoid and lateral pterygoid. Okay, so ipsilateral is your masseter and temporalis, and your contralateral is going to be your medial pterygoid and your lateral pterygoid. So if we do elevation of the mouth, it's going to be your masseter. So these are going to be bilateral working together. So bilateral masseters working together, bilateral temporalis, and bilateral medial pterygoids working together in elevation. And then depression we talked about. Depression is going to be your lateral pterygoids, as well as your suprahyoid muscles. So if you know your hyoids right here, it's going to be those muscles right underneath your neck down here. So that's also going to help with your depression as well as your lateral pterygoid. You guys haven't really gone over neck yet, right? You said? No? All right, the neck's a fun little area. So, I don't know, but you guys will get there. So protrusion, that's me like protruding my mouth out. I'm not very, like I said, my TMJ movements are not great. That would be me protruding my mouth, yeah, like that, Kyle. And so that will be bilaterally, that will be your lateral pterygoids, as well as your masseter and medial pterygoids. And then retrusion, which is the opposite of protrusion, it's going to be bilaterally your temporalis up here. And be careful with temporalis, because some people don't think temporalis is a muscle of mastication, but it definitely is. When you clench your jaw, I know everyone definitely feels it up here. So keep that in mind, that temporalis is a muscle of mastication.
What was it? Not protrusion, but what's the opposite?
Retrusion will be your bilateral temporalis, yeah. And then, okay, general, just like mouth opening would be your lateral pterygoid and your suprahyoid muscle group. Oh, so that's just the same thing as depression. We pretty much put it twice. I don't know why we did that, but depression and mouth opening, same thing. Lateral pterygoid, suprahyoid muscles. You guys haven't talked about force couples, have you? I doubt it. It's more of a kines concept, so I won't get too much into that if it's not something you guys know. But I mean, if you want to write it down later, it's a force. Your lateral pterygoid and your suprahyoid muscles are going to be a force couple. That's obviously, don't memorize that now, but if you just want to keep it in your notes for later, sure thing, go ahead. Um, yeah, so those are your muscles of mastication. Right. Any questions on those? Nope. Any other questions about anything else? If not, I do have my list of stuff from like the past 3 weeks that we can go over. Let's see. Is that okay with you guys? You guys just want to go over the list unless you have any other questions?
Real quick question. I got kind of confused. So the maxillary artery, does that come off the internal or external carotid?
I believe it's external carotid. Yeah, so your two terminal branches off your external carotid artery, and this is definitely probably going to be a question. Okay, so your two terminal branches of your external carotid artery are your maxillary artery and then your superficial temporal artery. And there is branches that come off of those, but as far as what they consider terminal branches of the external carotid artery, it's going to be your maxillary artery and your superficial temporal artery. Right? Any other questions before I head over to the list? No? Okay. So I'll start wherever. So cranial sutures. How familiar are you guys with your cranial sutures? These are easy anatomical questions that you could get wrong because you just overlook them. You guys know your cranial sutures well, or would you like me to go over it? No, you guys are good. Okay. You guys know what your pterion is, though? That part is important. You guys know what your pterion is?
Yeah,
Okay.
he really worked on that.
What was that?
Yeah, he went over that a lot in one of his voiceovers.
Okay.
Like
So I have a question for you about that then.
the,
What was that?
it's like the thinnest spot where you can get a blow to the head and it like lacerates your. Oh, that's probably gonna be your question, so I'll wait.
Yeah, so what artery is located there?
The middle meningeal.
Okay. And then so if I damage my medial meningeal artery through that pterion, what's going to happen?
Hematoma.
What kind of hematoma?
Epidural.
Yeah, it's going to be an epidural hematoma. So damage at your pterion damages your medial meningeal artery, which could lead to an epidural hematoma. That's definitely probably going to be a question on your exam. You guys said you're okay with cranial nerves, so I won't go over them. I might have sent a few of you, or I don't know how you guys memorize your cranial nerves. I can't repeat the way that we memorize our cranial nerves. If you guys want to text me, I'll definitely send it to you, but I can't repeat right now what we use. I'm pretty sure you guys figured out your own way. But yeah, definitely use mnemonics and stuff to memorize your cranial nerves and then figure out which ones are sensory and which ones are motor. we use another mnemonic for that. The clean version of that mnemonic is what is it? Some say marry money, but my brother says big brains matter most. The brains can be transferred to something else, but we'll use the clean version for right now. Um, um, but let's see what else I have here. You guys good with the holes of your cranium? You gotta know what goes through each hole of your cranium. I know it sucks. I don't know what picture he gave you guys to look at all that. We definitely have a picture on our PowerPoints with all the holes and stuff in them. But it is gonna suck studying them. I'm just gonna tell you guys that. So look at those for sure.
Are you talking about like all the foramens and stuff? And like,
Yep.
okay.
Yeah.
I got like the trigeminal ones down, but everything else is like.
Yeah. I mean, and then we went over some of them today in the orbital area, so maybe, and I think maybe that's a little more easier to memorize around the orbital area. But yeah, there's definitely a lot of holes and locations to know in there, so know those.
I would say to memorize the holes, what helped me was kind of breaking it down in the cranial fossas. So I like looked at the anterior cranial fossa and then looked at the holes that are in there and then memorized that and then like went down, and that kind of helped me with location and what hole and what goes into what.
Yeah.
And that's a good way of thinking about it too. There's, yeah, like I said, there's a lot of just holes in there, so you're gonna have to divide. I guess maybe like this is the eye area, this is like the middle part where the sella turcica lies and whatnot, and just all that stuff. But it's
Yeah,
definitely something you just sit down and have to stare at.
Dr. Liphart actually has a good chart on her PowerPoint in her lecture that I just made flashcards for, and she has like a whole chart that lists it all out. So that's what I've been studying, and it made it so much easier.
Yeah. I mean, whatever helps you guys. But like I said, it's just something you have to memorize. But speaking of these parts, do you guys know what is held inside the sella turcica?
It sounds familiar, but I forgot.
This is important. Do you guys, anyone else know what is held inside the sella turcica?
Is that the pituitary gland
Yes.
area?
So your
Okay.
pituitary gland is going to lie right in your sella turcica. And that's important because if you look at the sella turcica and its location to where the optic canal is, you'll see how close it is. So if your pituitary becomes enlarged or whatever, that's why sometimes people with pituitary problems have blindness, because it's located so close to your optic canal and where your optic nerve is, that it can cause some compression in those nerves, and then it can result in blindness. Okay. I would say understand that. That could be a question. If it's not a question in anatomy, I think it's a question in neuro. So for sure understand that.
Real quick, I'm kind of confused because I thought like that place where like the cavernous, is that the same place you're talking about where the cavernous sinus is and like the all the nerves run through that? Is that what the sella turcica is, or am I in a total different area?
No, I can show you real quick here if I can find. All right, tell me if you guys can see that. Yep.
Yeah, that's the picture we got.
Okay, yeah, so this space right here. Wait, make sure I'm in the right spot. I don't know why they don't. I don't know. This space right here is your sella turcica. This labeling is not I don't like this labeling that they used here, but this space right here is your sella turcica, and that's where your pituitary gland lies. And so your optic nerve or your optic canal is located right here, right? Like I said, so if you get pituitary problems that causes the enlargement right here of the pituitary gland, your optic nerves run right here, so they're going to get affected. So that's if you're more visual learner.
So the sella turcica is the same thing as a hypophyseal fossa.
So I think what they're saying from this picture is, so this area is the sella turcica, and then if you want to get like super specific, that little dent area right here is the hypophyseal fossa. I don't think you have to memorize that. I would just say this is the sella turcica. And I think sella turcica in English means Turkish saddle. I don't know if they told you that, but it kind of looks like a horse saddle in here. That helps you memorize anything. Right? Guys, familiar with the layers of your head using the the acronym SCALP? Did you guys learn that?
Yeah.
Okay. And this is something you guys probably learned in neuro too, but I would know your falx cerebri, tentorium cerebelli, falx cerebelli, diaphragma sella. No, that's a different thing. But know your falx cerebri and tentorium cerebelli, right? And your falx cerebelli, right? Any questions on that before I move to the brain ventricles and CSF? Nope. All right. So another question for you guys: which gyruses are your primary motor, and which gyruses your primary sensory?
Is precentral your primary motor?
Okay, and then what's your primary sensory?
Brain farting.
You don't need to think that hard.
That's the
So
post
precentral is
central.
primary motor. What was that?
I was just saying post central.
Yeah, it's post-central. So precentral, primary motor, post-central, primary sensory. I mean, easy way to just memorize that is usually, and this doesn't count for all the time, but usually things that are ventrally are more motor, things that are more posteriorly are more centrally. Like remember your ventral and dorsal roots. Your dorsal was your sensory, and your ventral was your whatchamacallit? What am I saying? Your ventral was your motor. So that's an easy way. Memorize those. I'm sure you guys have your lobes down. So the actual condition caused by when the pituitary gland is enlarged that affects at the optic, specifically at the optic chiasm, is going to be tunnel vision. That's the resultant condition. It's going to be tunnel vision. So your, I don't know how far you guys got into eyes in neuro, but that means your temporal fields are going to be affected.
Yeah, we went over it.
Yeah, I would know those eye charts. She definitely continually tests on those because people still don't understand them. But but definitely know those for her class. I mean, I'm not your guys' neuro tutor, but I can still give you guys tips on that.
I saw there's sorry.
No, you're good. What was that?
Oh, there's a neuro 2 as well.
Yeah, so neuro 2, honestly, I don't want to say it, but it's kind of a joke. I'll be honest. But so, because you would think neuro 2 would be harder than neuro 1, But no, Neuro 2 is very much more like application kind of stuff, like using what you learned in Neuro 1 and apply it to how you would treat a patient. So it's very much more applicable. It's a lot more about like motor learning and stuff like that for your patients and like feedback. Um, I mean, it's interesting, don't get me wrong, but it's not, as far as difficulty, it's not as hard as Neuro 1. So you guys can relax and chill and not think about that. But you have that to look forward to. Um, so I was saying, okay, what is the only cranial nerve that's not located on the brainstem?
It does. Ooh, that's spinal accessory, isn't it?
This is an anatomy question and it could be a neuro question as well.
It's not spinal accessory, is it?
No. Yes, no?
Good.
Is it the trochlear?
No. So it's gonna be your olfactory nerve. So your olfactory nerve is the only one not located on your brainstem. Your olfactory nerve is located more like inside your nasal area, right outside the olfactory bulb, I believe it's called, or ganglion or something like that. But that's where your olfactory nerve is gonna go. Right? Rest of these. How familiar are you guys with the ventricular pathway of CSF fluid?
Oh, could you go
Decent.
over that, please? I'm a little
Yeah.
familiar, but I just wanted to kind of sink in a bit.
Yeah, no, I'll definitely find a picture. For you PT guys, this is definitely also a neuro question. Here. Just let me know if you see that, okay? Yep. Okay. So these are the ventricles of the brain. It's this is the ventricles in its solid form. So typically on the brain, I'm going to move up to this or a picture up here. Typically, this is how your brain looks like. The ventricles are going to fill in these spaces right here, and we can go back to this picture later. It's going to fill in these spaces around this area and go down this way. So that's how it would be in a normal brain. But if we put it into a solid form, so we can look at the pathway, right? So CSF is created by the choroid plexus in the it's created in the choroid plexus in the subarachnoid layer. Okay, so that's where everything starts, in the choroid plexus in the subarachnoid layer. Okay, from there they're going to go to the lateral ventricle. So we start at the lateral ventricle, located around kind of where the corpus callosum is. So your lateral ventricle here. From there, it's going to go down into your interventricular foramen, right here, and then down into the third ventricle. So there's no first or second ventricle. It goes from lateral ventricle to third ventricle, okay? And I like to think of this whole thing as like a rooster almost. So this is the rooster's head and beak, and that's his eye right there. So the rooster's head is going to be the third ventricle. And then if we move on down to the cerebral aqueduct, all the way down to the fourth ventricle down here at the level of the cerebellum. Okay? And then from here it can go two different ways, or technically three different ways, but two different directions. So there's lateral openings, and there's two lateral openings and one medial opening. So the lateral openings, they just call them the lateral apertures here. There's one on each side, but the official name for these are the foramen of Luschka. Luschka. I have it right there. But so the foramen of Luschka goes laterally, so L goes with L. Laterally is Luschka. And then your one in the middle here, your median aperture, it's called the foramen of Magendie. Okay? And that will go medially, so your M goes with your M. Right? And if we move back to this picture right here, like I said, you can follow that same pathway that we went to using an actual brain here. So let's say there's, and this might not necessarily happen, but for the sake of the question, let's say something is happening around the level of the cerebellum, okay? Like there's an injury or trauma of some sort. What ventricle of the cerebrospinal fluid could be affected? You guys tell me?
The fourth one?
Yeah, because your fourth one's located right here at the level of the cerebellum, right? You can also have like a question about like if there's a thalamus injury, that'll be your third ventricle, right? So I would understand that. I would understand the pathway, but not only that, understand where their placement is within the brain. Or at least the general, just kind of where it goes when it's not in its solid form like this. You know what I mean? Right? Okay. Let's see here. So for you PTs and even PAs, this might be relevant, but for a traumatic brain injury, what is worse, the coup or the counter coup? You guys know what those are?
Yeah.
Did you say no?
I have no idea.
All right. I'll show you. Actually, I mean, I don't really need to show you. So your brain is like jello, right? It moves around your head like this, right? So if you have a traumatic brain injury, you're going to have two hits of your brain. You're going to have the initial hit, which is your coup. So let's say I hit like my head with a bat or something. That initial hit is called the coup. The initial hit on my brain is called the coup. And since my brain is like jello, it's going to hit forward with the coup and then backward. That's the counter coup. Okay, so it's going to hit the front of my brain with the initial contact and then the back of my brain with the end contact. And that'll be the opposite. Let's say I get hit in the back of my head instead. The coup would be on the back of my head and the counter coup would be on the front of my head. Okay? And this is for traumatic brain injuries. Okay? And then out of those two, the counter coup is worse than your coup. Okay? I don't know if this is something he mentioned, but it was in our PowerPoint slides, so I thought it was clinically relevant. Alrighty. So if we move on, we went over muscles of mastication already. You guys are familiar with your facial nerve branches, right? You learned this whole thing, right? Your head.
He has a slide on it, but I probably need to look over that.
Yeah, I would know those. This is putting your head like this and doing what the picture says, a really good way to memorize what part of the branch that you're on for your facial nerve. And so your facial nerve does your muscles of expression, and its location is inside and underneath the parotid gland. Okay, so if I have damage to my parotid gland, I can also get damage to my facial nerve, causing a lot of facial palsy as well, if that's injured. All right. Your parotid duct is located on your buccinator muscle. And this is something you might get mixed up. It's a matter of semantics. So there's two different things. You have your buccal nerve, and then you also have buccal branches. All right. So your buccal nerve is a branch off of your trigeminal. Your buccal branch is off of the facial nerve. Right. The buccal branch is from facial, buccal nerve is from trigeminal. That's an easy question to just mess up because you don't know which one's branch and which one's nerve and whatnot, right? We went over terminal branches of your external carotid already. The TMJ stuff. All right. Any questions there before I move to the oral region or pharynx area? Nope. All right. So if we move to the oral region and pharynx, um, this is not always the most interesting place for PTs because we're, like I said, we're more focused on like muscular kind of things, but definitely should be some interest to a lot of the PAs. But so, do you guys know the main innervation for the motor of your tongue? What nerve does that? Anyone?
Hypoglossal.
Yeah. So it does all the motor to your tongue except one. What is that? Do you guys know that one muscle and what's its innervation? No? All right. So for your tongue
What
muscles,
was the question? Sorry.
yeah, no, you're good. So the hypoglossal does all the motor innervation of your tongue except for one muscle. What is that one muscle and what's its innervation? Anyone else before I just give the answer? Okay. So it's gonna be your palatoglossal. Your palatoglossal is a soft palate muscle, but also a tongue muscle, right? That's why it's innervated by the vagus nerve and not the hypoglossal. Okay. Innervation of your tongue. I'm just gonna, since we have maybe like 5 minutes left, I'm just gonna run over these real quick. But your lingual nerve is off of your V3 trigeminal, which is your mandibular, and that's going to do your general sensory of your tongue. So that's touch and temperature. So if I just like touch my tongue or I put something hot on my tongue or cold on my tongue, it's going to be my lingual nerve. That's off cranial nerve V3, right? Your facial nerve, cranial nerve 7, is going to be your anterior taste of the anterior 2/3 taste of your tongue. In specific, the nerve is called the chorda tympani nerve. I don't know if he's gonna specify that, but so the chorda tympani is off cranial nerve or facial nerve, cranial nerve 7, and that's the anterior 2/3 taste. Right? Your posterior 1/3 taste is from your glossopharyngeal cranial nerve 9. Your cranial nerve 10, your vagus nerve is going to do a gag reflex. So when you guys go over like cranial nerve assessment to test for cranial nerve 10, one of the ways you can do it is to stick like a popsicle or something down someone's throat or whatever and make them gag. Be like, all right, their cranial nerve 10 is intact or impaired or whatever. And then cranial nerve 12, your hypoglossal, like we said, is going to be the motor to your tongue, right? Let me share this picture with you so I can bring up an important point here. All right, let me know if you see that okay. Yep, all right. So here are your tongue muscles. We have your genioglossus, hyoglossus, styloglossus, and palatoglossus, right? An easy way to memorize like origin insertion is really just look at the names, right? Hyoglossus, it's going to be on your hyoid and attaching to your glossus area, which is your tongue area, okay? Styloglossus comes from your styloid process. Palatoglossus is from your soft palate, okay? What I wanted to point out is the genioglossus here. So the genioglossus is going to be the bulk of your tongue, like it says. So this all right here is genioglossus. But when we were in cadavers, this is something we should keep in mind, is you do have two suprahyoid muscles here, right underneath the tongue. So if we separate right here in this area, you're going to have your geniohyoid right under your genioglossus, okay? So, and then right under your geniohyoid is going to be your mylohyoid, all right? And in cadavers, you could easily separate these out, and he could easily be like, all right, what's this muscle right in the middle of genioglossus and mylohyoid? And you would have to figure out that it's geniohyoid, okay? So I would understand this little, I guess, sandwich layer right here. So genioglossus, geniohyoid, then mylohyoid. And even though geniohyoid and mylohyoid are your suprahyoid muscles, they're still going to be in this area forming the base of your tongue here, right? Let me just, the last thing I'll do for you guys, I'll go over the soft palate really quick. All right, so right here we have a mouth, obviously. Okay, so the end of your soft palate is going to be your uvula. And your uvula muscle, it has its own muscle. It's called the musculus uvulae. Okay, so your uvula is the end of your soft palate, and its muscle is the musculus uvulae. You have two arches right here, one more anterior than one posterior. Your anterior arch is going to be your palatoglossal arch on either side. That's just part of your palatoglossal muscles. Okay, so your palatoglossals are going to be more anterior than these arches here, which is your palatopharyngeal arches, which is part of your palatopharyngeus muscles here. Okay, so palatoglossal is more anterior than the palatopharyngeal. Okay, and like I said about the palatoglossal muscles, they're also a tongue muscle, even though they're kind of located in the soft palate. And that's the one innervated by the vagus nerve, not the hypoglossal. All right? So additional muscles in the area. So all the muscles of the soft palate are palatopharyngeus, levator veli palatini, tensor veli palatini, and additional information on the tensor veli palatini. It has function on opening your eustachian tube when you swallow. That's why when you swallow, you have this ear sensation. That's due to the tensor veli palatini. We also have your palatoglossus, like I said, palatopharyngeus. I think I said that twice. And then your musculus uvulae. Right? Those are that. All right. Any questions for me before we go?
Thank
There's
you.
a lot of talking for me. I'm not used to being the only one talking in this thing, but
You rocked
you know,
it.
yeah,
Thank
we
you so
try.
much. I really appreciate it.
Yeah,
Yeah,
thank
no
you.
Yeah,
problem.
thank you.
Anytime. Yeah, so we have tutoring again on Friday. I mean, you guys don't have to show up, but yeah, we'll see you again on Friday, okay?
Thank
see
you.
you.
It's Friday at 1.
Yeah, Friday's at 1.
Okay. Thank
Mhm.
you.
All right. See you guys.
Yeah, man.